Now, cardiovascular system. Rheumatic fever is an inflammatory disease that occurs after an infection with group A beta hemolytic streptococcus. Group A beta hemolytic streptococcus. And in the med-surg section, y'all remember us studying that strep. We said that strep loved to attack two organs, heart and kidneys, right? Right. Now, the major cardiac clinical manifestation of rheumatic fever is carditis. Carditis. Therapeutic management for rheumatic fever includes, well, the drug of choice is penicillin G, or if somebody's allergic to penicillin, that's when they're going to get erythromycin. Erythromycin. Now, another problem in the cardiovascular system is called Kawasaki disease, and it's characterized by widespread inflammation of the small and medium-sized blood vessels, with coronary arteries being most susceptible. So the treatment for Kawasaki disease consists of high-dose IV immune globulin, okay, salicylate or aspirin therapy, bed rest. Now, what would be the nursing assessment of a child with cardiac dysfunction? Well, on your handout it says assess nutritional status. You may see failure to thrive, poor weight gain, fatigue with feeding, and poor feeding habits. Maybe they won't take their bottle. Okay, that's one of the earliest signs of a heart defect is the baby that can't complete an entire feeding because during the feeding they get so worn out they just pass out. Okay? Now, color, chest deformities, unusual pulsations, respiratory effort, clubbing of fingers, behavior, knee-chest position or squatting seen in some types of heart disease. Okay? We're going to talk more about that in just a little bit. Excessive sweating during feeding is also associated with heart disease. Excessive sweating. Now, what is congenital heart disease? It is a structural or functional defect of the heart or great vessels present at birth. In children, types of cardiac defects are classified by blood flow patterns. Blood flow patterns. And I've got you some examples listed there. All right, now we're going to talk about general overview of heart problems in children. Now, we're just talking in general now, and in a little bit we're going to talk about some specific heart defects, okay? Now, CHF is usually due to congenital heart defects in children. Now, we've got some early signs and symptoms here. Increased pulse at rest, underline at rest, and with slight exertion, increased respiratory rate, scalp sweating, that's mainly seen in infants, fatigue. I mean, anytime that you have a heart problem, you can't compensate for increased oxygen demand, so the patient will be tired or sudden weight gain. 1 pound or more in one day is fluid, okay? We're talking about in the baby now. Now, so what are some things we want to do? Well, listen to the lungs, of course. Control the room temperature, because we already know that any extreme in temperature increases workload on the heart, and we don't want to increase workload. Sit up, sit the baby up, or the child. That's going to decrease workload. Rest a lot. Decrease stimuli. We're doing everything we can to decrease workload. Cool, humidified oxygen, and uninterrupted sleep. That's very important. Anytime you have a baby or a child with a heart defect, you've got to give them uninterrupted sleep. Nutrition. Well, we want them to be well rested prior to eating. We need to feed when they wake up and when they're showing signs of hunger, like sucking their fists, that sort of thing. You're trying to decrease crying. In other words, don't wait till they start crying before you think, well, maybe it's time to feed them. We don't want them to cry because that crying really increases workload on the heart. Small, frequent feedings are not as tiring, and it is okay to increase the calories in the feeding because they have an increased metabolic rate. Now, a good feeding schedule for a heart baby is about every 3 hours. Every 2 hours doesn't give the baby enough rest in between, and then if you wait every 4 hours, then the baby's going to have to drink or take in more volume, which increases workload on the heart. They can't handle that. All right, so every 3 hours is the best. Now, it takes about 1/2 hour for an infant to take a complete feeding, okay? Now, prolonging the feeding leads to exhaustion and decreased rest periods, all right? So we don't want to prolong it more than a half an hour. We want to use a soft nipple with a larger opening so the baby won't have to work so hard to get the formula out, okay? That way they can, like you may open the end of the nipple a little bit more so they won't have to suck as hard because sucking increases workload on the heart. Now, they may need gavage feedings, especially if they're having respiratory distress. They may not be able to handle nursing from a bottle. They may have to be gavaged. Breastfed babies may need additional supplements for calories and usually do not have to restrict sodium in babies. A lot of adverse side effects associated with that. Now, rarely do they need fluid restrictions because it's hard to get them to take fluids anyway, so they're not really taking a lot of fluid in, whereas in the adult, we always restrict fluids, okay? But you don't really have to do that in the baby. Now, there's some specific points I want to make about DIG because DIG is still used frequently a lot in the infant and the child, okay? Main signs of toxicity, bradycardia, and vomiting. Vomiting being the earliest sign, so we always want to work for that. With infants, we're going to hold if the pulse is less than 110. Children, hold if the pulse is less than 70. But use judgment. Always compare to previous readings, all right? Normal DIG level is 0.8 to 2. And infants rarely get more than 1 cc, all right? Now, the only reason I say that is because if you are giving a baby DIG and when you're calculating your problem, you draw up 2 cc's, that should be a red flag to you because rarely, that's just kind of a rule of thumb, rarely do they ever get more than a cc. Now, give 1 hour before or 2 hours after feedings. You want that medicine to have time, the DIG to have time to have kicked in before they eat, so their heart will be working well and they won't get so worn out during their feeding, okay? Do not mix with food or fluid because then you don't know how much of it they're really going to get, okay? There's no guarantee they're going to take all of their food or fluid. Now, 4 hours past due on the dose. Okay, well, we're going to hold the dose and give the next dose on time. If the baby vomits, don't give more because there's no guarantee as to how much they lost when they vomited, how much of the medicine they lost when they vomited. Now, if they miss 2 doses in a row, we need to call the doctor or the nurse practitioner. Do not increase or double the dose, and always check the dose with another nurse, okay? Because we're dealing with infants and children here, so we have to be even more careful. Now, ACE inhibitors are also used, and some common ones that are used are Capitan and Vasotec. Now, some things you need to watch for here are decreased blood pressure, kidney problems, and a cough. Now, that cough can occur in the adult, too. It's just a dry cough. And if you ever have a child or an adult that starts that dry cough, then the medicine needs to be discontinued, and they need to be put on something else. Now, how do ACE inhibitors work? Well, they block aldosterone. So we're not retaining as much sodium and not excreting as much potassium. Therefore, aldactone and potassium supplements may not be needed and could cause hyperkalemia. Okay? That's just something you need to think about when you're dealing with ACE inhibitors. Now, as with any heart person, Lasix may be needed to decrease that volume. And infant formulas have more sodium than breast milk. That's just something to keep in mind. Now, also with cardiac babies, they can have what is called hypercyanotic spells, which we're going to talk more about those in a little bit. But for right now, what do you do for a hypercyanotic spell? Well, if it's an infant, you put them in the knee-chest position. In other words, you wad them up in a ball, and then normally they'll start oxygen, 100% O2. And if it's a baby, they'll lay the oxygen by their face and let it blow by their face. They call it blow-by oxygen, okay? Also, morphine for sedation. If they're in the middle of one of these hypercyanotic spells, they may have to give them a little morphine to hurry up and get them calmed down and to hurry up and decrease the workload on the heart. Also, with heart babies and children, we always monitor cardiac output, just like we did in the adult. Some other things to remember: loose clothes and loose diapers. You don't want anything that's going to restrict their breathing in any way. Quiet play, no stress. You have to pick activities that decrease the workload on the heart. Respond to crying quickly. Remember, when you have a baby that's crying, the workload on their heart is really increased, so you don't let them cry a long time before responding. And if they get an infection, it has to be treated promptly because they can't handle fever. Fever is going to increase workload on the heart. Now, some other cardiac information. First of all, effects of chronic hypoxia. And notice I said chronic hypoxia. Well, the first thing, polycythemia. That's when you have increased red blood cells. Well, why does that happen? Because the body senses that it's hypoxic, all right, from the cardiac defect. All right, so the body feels it's hypoxic, so the bone marrow thinks, okay, I'll make a whole bunch more red blood cells to carry more oxygen. Well, that's well and good if there was more oxygen to carry, all right? There's no more oxygen to carry, though. So this makes the blood really thick, and this can lead to a stroke, yes, even in a baby. So we've got to keep them hydrated, keep that blood thinned out. And another important point about polycythemia is you've got so many red blood cells, there's no room for platelets. So now we may have a baby or a child that's thrombocytopenic, and we all know what that can bring about. Clubbing is also another effect of chronic hypoxia, and this is when we have thickening and flattening of the fingertips and toes, specifically the nail beds we're talking. Poor growth may also be seen in chronically hypoxic children. Anytime you have a disease or a disorder where there's hypoxia, expect growth to be decreased. Like with cystic fibrosis children, they're always hypoxic because they have got a little bit hypoxic since they have all those thick, sticky secretions in their lungs. Squatting. Now, squatting is not seen much as we used to see it because we identify heart problems so much earlier. I mean, most heart defects are identified within the first year usually, okay, before the child even has time to walk. Used to, when I was in nursing school, they would tell us to watch children. And when they would be on the playground, if they squatted down, that could be a sign of a heart defect. Also, we've already mentioned the hypercyanotic spells, also known as blue spells or TET spells. That is something seen primarily in tetralogy of Fallot. And just a point I wanted to make as an aside, 50% of brain growth occurs in the first year of life. Well, if you've got a child in that first year of life who is hypoxic for whatever reason, like a heart defect, you've got to consider that if 50% of their brain is growing in the first year of life and they've been hypoxic during that time, they could have some significant developmental delays. Now then, we're going to get into specific heart defects now, and you're going to see that this is just not near about as difficult as it was in school. I have all of the notes written out for you, so all you have to do is really listen, okay? And the first ones we're going to talk about are the acyanotic defects. Now, with the acyanotic defects, you will see that the name of the defect pretty much tells you what your problem is. And on all of these defects, just about, I have a square heart drum. And wherever you see the X, that's where the hole is. That's where the defect is, okay? So let's talk about it. Ventricular septal defect. Well, first of all, which side of the heart is stronger, left or right? The left side of the heart is always stronger than the right. Well, this is when there is an opening between the right and left ventricle in the septum. Okay, so there's a connection between the right and left ventricle, not supposed to be there. Now think with me. When the left ventricle squeezes down, it shoots blood forward into the aorta like it's supposed to. But now, since there is a hole between these two chambers, blood can now shoot over to the right side of the heart, the right ventricle. Since the left ventricle is the strongest part of the heart, when it squeezes down on blood, it does so with great force. So therefore, it really shoots blood over to the right side. This increases the volume on the right side of the heart. The right side is having to pump harder, so this can lead to right-sided heart failure. Okay, so let's just talk. There's an opening between the left and right ventricle. In the septum, the left ventricle is so strong it squeezes down with great force, and yes, blood goes forward like it's supposed to, but now that there's a hole there, blood can also shoot over to the right side of the heart. So that increases the volume on the right side of the heart, and this can lead to right-sided heart failure. You're going to see as we go through these acyanotic defects that we're either ending up with right-sided failure or left-sided failure. All right. Now, many close spontaneously during the first year of life. And how do we know someone even has this? Well, they might have signs of heart failure or a significant murmur that we pick up on routine physical exam, and so the doctor's going to do further investigation then. Now, atrial septal defect. Which is stronger, the left atrium or the left ventricle? The left ventricle is the strongest part of the heart, but is the left atrium still stronger than the right atrium? Yes. Okay, because the left side's always stronger than the right. Now, there is an opening between the right and left atria in the septum. Okay? This is the exact same thing we were talking about before, but that defect was down in the ventricles. Now, this one's up high in the atria. When the left atrium squeezes down, some blood goes forward into the left ventricle just like it's supposed to. But since there is a hole in the septum, blood can not only be pushed forward, it can now go to the right as well. So you got blood going forward and you got blood going over to the right side of the heart. When the left atrium squeezes down, it is not as forceful and strong as the left ventricle, but it is still stronger than the right atrium, so the left atrium is overpowering the right and blood moves to the right. Now, this is not as big a deal as VSD, the one we've already talked about, because the blood is not being shot over to the right with great force. Now, how do we know someone has it? Well, your child may be asymptomatic, may have signs of heart failure, murmur, and atrial arrhythmias. I mean, think about that. The atria in this condition are going to be all stretched out and big because more volume's up there. So that's going to affect the electrical component of the heart. So you may see atrial arrhythmias. Most common treatment is surgery prior to school age. Now, patent ductus arteriosus. Patent ductus arteriosus. Now, the first thing we have to do is we have to understand normal fetal circulation, okay? Normal fetal circulation. Blood goes right atrium, right ventricle, pulmonary artery, but doesn't go to the lungs. Instead, when blood leaves the pulmonary artery, it goes straight over to the aorta via the ductus arteriosus. Now, why does the blood do this? Because in utero, the baby's lungs are collapsed and the baby's getting their oxygen through the placenta. Okay? So if you'll look at your picture, you'll see the way the blood is going. Okay? It's going right to left, right to left, right to left, bypassing the lungs. Now, look at the next sentence. This ductus arteriosus is supposed to close when the baby is born and takes their first breath. Well, when it closes, then blood flows from the pulmonary artery to the lungs, just like in the adult. Now then, think about the left side of the heart in this condition. Now, here's the problem. When the baby's born and they take their first breath, the ductus arteriosus in this condition is not closing. It's not closing. There's still an opening there. There's still a connection between the pulmonary artery and the aorta. All right, now let's think about the left side of the heart. Here comes the blood, left atrium, left ventricle, and then the blood moves into the aorta. When the blood gets into the aorta, it's confused as to which way to go. The blood says, should I go straight to the body like it's supposed to, or should I hang a right here through this opening that was supposed to close? There's a traffic jam of blood in the aorta because the blood doesn't know which way to go. Okay. This leads to increased workload on the left side of the heart and therefore left-sided heart failure. Some blood is going straight like it's supposed to, but some of it is going to the right because the left side is still stronger than the right. Okay? And the aorta is considered to be part of the left side of the heart. So the aorta is stronger than the pulmonary artery, so it's overpowering and the blood's going that way. Now, how do we know someone has it? Well, they might be asymptomatic again. They may be in heart failure, but this one has a weird machinery-like murmur. All right? Now, treatment. Indomethacin, which is a prostaglandin inhibitor, will close PDA, and then, or they might have to have surgery. All right. Now, the next one is called coarctation of the aorta. The aorta has a narrowing, all right? Pretend there is a tourniquet tied around the aorta. This makes it harder for the left ventricle to pump, so the patient may wind up with left-sided heart failure. Think about that. The aorta's got a tourniquet around it. Well, the left ventricle squeezing down on the same amount of blood, but it's having to pump the same amount of blood through a smaller opening because there's a tourniquet around the aorta, so the workload on the left side of the heart just went up. Now, how do we know someone has it? There is a big difference in the pulses and blood pressure of the upper and lower extremities. That's why your teacher always told you when you're doing vital signs in a pediatric patient to always get the blood pressure and pulses of the upper and the lower extremities. Now, there is always a slight difference in the pulses and blood pressure of the upper and lower extremities. Always a slight difference, okay? Your arm pressure is always going to be higher than your leg pressure. Okay, that's just the way it is. But that's why I said on your handout the word big in bold letters. There's a big difference here. The upper pressures are much greater than the lower pressures. Now, treatment, surgery, and then in some they can do angioplasty. Pulmonic stenosis. First, you have to know where the pulmonic valve is located. All right, so that's the first thing you have to know. The opening in the valve is very, very small. The right ventricle has to work harder to pump the same amount of blood through a smaller opening. The patient may develop right-sided heart failure. Well, think about that. The poor old right ventricle's working hard to pump the same amount of blood through a smaller opening, so the workload on the right side of the heart just went up. Right-sided heart failure. Now, how do we know someone has this one? Again, they could be asymptomatic or they could be in heart failure. We may hear a murmur or we may see an enlarged heart on the chest x-ray. Treatment, surgery, again, maybe angioplasty. Now, just as a common rule here, look at the next statement. With all heart defects, the child is at risk for bacterial endocarditis, and this may be how the defect is first discovered. Maybe they get put in the hospital for endocarditis, inflammation of the heart, or bacterial endocarditis. And also, I've already said this, but I'll say it again. An early sign of any heart defect would be feeding problems. A baby that won't take their whole feeding, or they just pass out from exhaustion every time they take their feeding because they can't compensate for the increased oxygen demands that have been placed on the body. Aortic stenosis. Now, this is the exact same thing as pulmonic stenosis, but now we're talking about the aortic valve. All right, same thing. So when the left ventricle squeezes down to shoot the blood into the aorta, it has to do so with greater force to get the blood through the smaller opening. This just increased the workload on the left ventricle, and now the patient is at risk for left-sided heart failure. Remember, with aortic stenosis, the opening in the center of the valve is teeny tiny, very, very small. So that left ventricle is working hard to pump the same amount of blood through a smaller opening. So the workload on the left side of the heart just went up, left-sided heart failure. Well, how do we know someone has it? Well, they may have signs and symptoms of a decreased cardiac output, a murmur, or they could be in heart failure. Now, I know we went over those defects fast, okay? But all of the notes are there for you. You probably just need to read the notes again and get an idea in your mind. Once you hear the name of the defect, you can pretty much figure out what's going on in the defect, okay? Now, the cyanotic defects are a little bit different. The first one, tetralogy of Fallot, which consists of 4 defects: ventricular septal defect, pulmonic stenosis, an overriding aorta, and right ventricular hypertrophy. Well, how do we know someone has it? Infant may be cyanotic at birth, and others may have mild cyanosis that progressively worsens during the first year. So this isn't something that necessarily is picked up on at the time of delivery. They may have a murmur, and then this is the one that can have the acute cyanotic or hypoxic spells that we talked about earlier. Blue spells, tet spells. Now, these spells are usually seen during crying, after feeding, or during a bowel movement because all of those things increase workload on the heart, and they can't handle it, so they turn purple. Now, why are these TET spells or blue spells so important? Because they can lead to sudden death and seizures because they're so hypoxic. Older children, this is where you may see the squatting, the clubbing, poor growth, and exercise intolerance simply because they're so hypoxic. Treatment, surgery. Now then, transposition of the great vessels. Transposition of the great vessels. To understand transposition, the first thing we've got to look at is the normal heart. Now let's get this normal heart thing straight. Notice that the pulmonary artery comes out of the right ventricle and goes to the lungs, and then the blood goes to the left side of the heart to get pumped out to the rest of the body. So the PA's favorite place to go is to the left club. I call it the left club just to make it more fun. So the pulmonary artery wants to go to the left club. All right? Keep that in mind. Notice the aorta comes out of the left ventricle and then goes throughout the body and eventually winds up back at the right side. So the aorta's favorite place is the right club. Okay. You got your left club and your right club. You've got to first figure out where their favorite place to go is. And we've said that the PA's favorite club is the left and the aorta's favorite club is the right. Now then, let's look at the abnormal heart. Notice the pulmonary artery and aorta have swapped places. But here's the deal. They're still going to their favorite club. We said that the aorta's favorite club is to the right. Well, the aorta's coming out of the right ventricle and still going to the right side of the heart. Now, the pulmonary artery's favorite club is the left. And now it's coming out of the left ventricle and still going to its favorite club, which is the left. So what you wind up with would be two separate sets of circulation just circulating in and out of the heart, in and out of the heart. Yes, some blood is getting out to the systemic circulation, or the patient would be dead at birth. Instead, the baby is cyanotic at birth, but they're still alive. So what's keeping the baby alive? Well, there is some other defect that is allowing the baby to get just enough oxygen to stay alive. And you may say, well, what defect is it? Who knows? It's different in different babies. But it's something that's giving that baby just enough oxygen to stay alive. They're still cyanotic at birth, but they're alive, okay? Well, how do we know someone has it? Usually cyanotic at birth. But if for some reason it's not picked up on until older, you may see decreased growth, poor feeding, and of course the treatment's going to be surgery. All right. Now, just miscellaneous information now. Why are new foods introduced to children one at a time? Because what are we worried about? Allergies. Allergies is what we're worried about. Now, what is the most common reason for failed toilet training? They're just not ready. They're just not ready. In children up to 1 year of age, what are the major causes of accidents? Falls, poisonings, and burns. Falls, poisonings, and burns. What is a common symptom of head lice? Itching. Itching. And can lice go to other body parts besides the head? Yes, they can go anywhere they want to go, can't they? And how are lice spread? Personal contact. Personal contact. Now, something more pleasant, pinworms. How are pinworms spread? Hand to mouth. Hand to mouth. And how do you collect a specimen to diagnose pinworms? Well, they say the tape test. Tape to the rectum. Tape to the rectum early in the morning before the child wakes up. Early in the morning before the child wakes up. Now, we say before they wake up so they won't freak out, right? But why do we say early in the morning? Why is early in the morning the best time to collect this specimen? Because what do the worms do early in the morning? They crawl out of the rectum and lay their eggs. That's why the eggs can be out in their underwear and all out on the sheets, okay? And then after they lay their eggs, they go back home again, don't they? Yes. Now, let's talk about pinworms just for one more second. Any child who plays outside in their sandbox or writes their name on the car in the dirt, in the dust, whatever, and then eats some Cheetos without washing their hands, they could introduce those eggs into their GI system, because where do the eggs live? Dirt and dust, okay? So any child that's playing outside and not washing their hands all day is at risk for getting this. And the whole family has to be treated, because the eggs can be everywhere that child has been. So the whole family has to be treated, and this is when you have to teach them about getting all the sheets in the house washed really good and make sure they clean the bathrooms really well, that sort of thing. Chickenpox is rare due to the varicella vaccine. However, if a child does contract chickenpox, the primary focus is to prevent infection in the lesions. And what home remedy can alleviate the itching associated with chickenpox? Well, the first thing most people say is an oatmeal bath, and that's a good answer, oatmeal bath. But another mixture that you can use is baking soda paste. Baking soda paste, and you just take a little baking soda, mix it with water, and smear it on. It'll help dry up the lesions. And here's a hard question. Are chickenpox contagious? Yes, they're very contagious. It's the same thing that gives us what when we get older? The shingles. It's the same virus. You know, if you have chickenpox when you're little, then that virus is lying dormant in your body. And then when you get sick or stressed out one day, it may resurface and you get the shingles then. Now, what happens to the growth rate between 6 and 12 years of age? Decreases. It slows down, but they're about to have a growth spurt, aren't they? Yes. How much earlier do girls experience the onset of adolescence? 1 to 2 years. 1 to 2 years. Okay. And that's so evident on the 6th grade playground in the springtime. If you go to the 6th grade playground during April, and you can look at all the little girls, they're all huddled up together with their mini skirts on and their makeup on and their purse on their shoulder, all huddled up together looking at who? The boys. Where are they? On the monkey bars, aren't they? Yes. They hadn't caught up yet, but they will. Now, what is the name of the virus that causes infectious mononucleosis? Epstein-Barr. Epstein-Barr. And how is this virus spread? Yes, it is called the kissing disease. Direct, intimate contact. Direct, intimate contact. Now, that doesn't mean necessarily that your child is kissing somebody. Your child may be having direct, intimate contact with the water fountain. I mean, have you ever seen a 4-year-old drink out of a water fountain? They want to put their whole mouth over it, don't they? Yes. All right. Now, how should a child be positioned after a tonsillectomy? Think for a second by yourself and see how many different positions you could come up with that would be appropriate. I bet your friend said on their side. Yes. Elevate the head of the bed. Yes. We always want the head of the bed elevated. Now, there's another position that's appropriate, too, that you just don't see a lot of people in the hospital. Anybody know what it is? Prone on the stomach. Now, y'all, if they're prone, don't elevate the head of the bed, okay? That wouldn't be comfortable, now would it? No. And the purpose of all of these positions is to prevent aspiration. Prevent aspiration. Now, after a tonsillectomy, why are brown colored or red fluids not given? Because we don't want anything to get confused with blood. And after a tonsillectomy, what would indicate that hemorrhage is occurring? Frequent swallowing. Frequent swallowing. And how many days after a tonsillectomy is a child at risk for hemorrhage? Up to 10. Up to 10 days. Common complaints after a tonsillectomy. Okay, go ahead and write down sore throat, because everybody knows that, right? Yes, sore throat. Slight ear pain. Slight ear pain. If they start having too much ear pain, we would have to assume an infection, wouldn't we? Yes. Low-grade temp is normal. Low grade, I said. If they spike a temp, that means infection. And then the last thing we have there that you need to write down is bad breath. Now, why do they have bad breath? Old blood in the throat. Old blood. Now, the next thing we have is otitis media. Well, what part of the ear is affected with otitis media? The middle ear. The middle ear. What is blocked with otitis media? The eustachian tubes. Eustachian tubes. And otitis media usually follows a what? Upper respiratory infection. Upper respiratory infection. Now, what would the tympanic membrane look like with otitis? Bulging and bright red. Bulging and bright red. Now, if it's bulging, that means it's got pressure and fluid behind it. So therefore, it could go ahead and rupture, which might be the very best thing that could happen is for it to rupture so all that infection can come out. The tympanic membrane will grow back together. Sometimes it has to be sewn back together, and that's why you can have some hearing loss with otitis. All right? Can hearing loss occur with otitis? Yes. Do heating pads help the pain? Yes, heat will help. And sometimes you can alternate the heat with ice packs. The ice will help decrease any swelling, okay? Treatment for otitis media. I've got several things I want you to write down here, okay? First of all, avoid chewing. Avoid chewing. Chewing makes the pain worse. They need soft foods, okay? Soft foods. We want them to lie on the affected side. Lie on the affected side that promotes drainage out of the infected ear. We want to prevent if we can. And one way to prevent is to have the baby sitting up for feedings. Sitting up more for feedings, and no bottle propping. We know that's bad. No bottle propping. Another way to prevent is this. When a child blows their nose, you do not want them to blow their nose really, really hard. Now, you'll hear parents say, blow hard, but you don't want them to because that can actually shoot infection back up into the eustachian tubes and cause otitis. So gentle nose blowing. And anytime your child has an upper respiratory infection, it's good to get them to play blowing games, like blowing up a balloon or blowing a pinwheel, something like that, because that helps keep the middle ear open, helps keep it aerated, helps keep it clear. That's a good thing. All right. Also, any form of smoke can precipitate otitis, so you don't want the child to be around any smoke. And remember to teach the parents that the child may not can hear you. So if they're not ignoring the parent, they just can't hear. So they need to know that so they won't get upset with the child for not responding to them. And then if you have a child who ends up having to have tubes put into their ears, like they call them tympanotomy tubes or pressure equalizing tubes, that keeps the middle ear drained. Remember, anytime they have tubes in their ears, they have to wear earplugs when they're in the bathtub or when they're going swimming, that sort of thing. Now, also, if the earplug, also called a grommet falls out, it's okay. It's not an emergency. You do need to let the healthcare provider know that they've fallen out, but usually they're not going to worry about it. It's just a little white plastic thing. Just make sure the parent knows that it's okay. Now, what are PE tubes? Pressure equalizing tubes. That's what that stands for. Pressure equalizing tubes. And how long do tympanotomy tubes stay in place? That's just another name for tubes. Average is 6 months. Average is 6 months. I know most people say until they fall out, right? All right. Now, why are peanuts so dangerous when aspirated? What will a peanut do? Swell and crumble. Swell and crumble, which makes it very difficult to remove. And you know, lots of children have peanut allergies too, so that's something you really need to be cautious about. Often, the mentally challenged child will deliberately do things to displease the parents. Why? For attention. For attention. When giving IM injections, why is the dorsogluteal muscle contraindicated in children who have not been walking for at least a year? It's not developed. It's not developed. And when an infant has had a perineal surgery, what position would you place them in post-op? And prone is contraindicated. On their side. On their side. Now let's think about that. We have an infant with a perineal surgery. There's lots of surgeries that you can have in the perineal area, but it's a baby. And anytime you put a baby on their stomach, what's the first thing they want to do with their legs? Pull them up underneath themselves and wad up in a ball. Well, if you have a perineal incision and you lie on your stomach and pull your legs up underneath, what did you just do to the incision? Stretched it, right? Yes, you stretched it out. That's why prone is contraindicated and side lying is the best answer. To decrease stress on the suture line. To decrease stress on the suture line. And then last we have an infant has just had an inguinal hernia repair. What is the major problem post-op and how can it be prevented? In other words, you've got a baby again with an incision in the inguinal area. What's going to be your biggest problem? Infection. Infection is going to be the biggest problem, and about all you can do are frequent diaper changes. Frequent diaper changes. All right, now, don't forget now on your CD, we've got some growth and development information there for you and your immunization information. All right, y'all keep studying hard. That's it for pediatrics.